Hi, my name's Allysa Saggese. I'm a nurse practitioner at Weill Cornell Medicine in New York City, and I'm here today to talk about MASH and MASLD and type 2 diabetes and concurrent medication management. So our first question is, why are patients with type 2 diabetes particularly high risk for developing MASH and advanced fibrosis? Well, all metabolic syndromes come together to cause a lot of similar issues in the body. So the presence of an elevated glucose makes the body want to store it. Storing it usually is fat. Fat can get stored in the liver and it doesn't belong there. So when enough fat is in the liver, it's irritating to it. And over time, if the fat does not move out, then it can cause damage because it's a constant irritation. It's just like cutting yourself in the same spot over and over. It causes a scar and it can cause scarring throughout the liver. And it can just continue to progress. So type 2 diabetes is a situation where there is higher blood sugars and therefore that process is occurring. In reverse, when someone has fatty liver, they can be more at risk for type 2 diabetes because of the same processes in the other direction. So either way, when you find one or the other, you should be also monitoring and managing and assessing for type 2 diabetes or MASH and advanced fibrosis. Our second question has to do with discussing the effects of standard type 2 diabetes medication classes, for instance, Metformin, GLP-1s, SGLT2 inhibitors, TZDs, on liver fat inflammation and fibrosis, and which are considered potentially beneficial for MASH. So historically, Metformin is one of the first diabetes medications, and it does have some effect on fat in the liver. It can help with it lowers blood glucose, as we know, but it can also help with reducing the making of fat in the body and in the liver. Its effects are not so potent that it is considered a treatment for fatty liver, but it can help when someone is already on it. Secondly, historically, Pioglitazone has been a medication for a long time. It's been associated with helping to potentially treat fatty liver. And a lot of providers for many years were having patients on this medication when they found fatty liver and or diabetes as well. It is a PPAR delta or a PPAR agonist that can improve insulin sensitivity. And so the way it works for diabetes is helping with managing blood sugar, and in helping managing blood sugar, then you can help the fat not be deposited in the liver and you can help the metabolic state of the person. And it has had more effect on hepatic fat and it has helped liver inflammation, therefore helping fibrosis. It doesn't act directly on fibrosis, and it has some benefit in patients with fatty liver, but again, not enough to be considered a true treatment for fatty liver. And then we have the SGLT2 inhibitors, again, have an effect on blood glucose and therefore on fat in the body. It helps to some small extent with potential weight loss, maybe just some fat reduction, and that would help more indirectly the liver fat. But it's not been robust enough to make it a goal treatment for people with fatty liver. What is the most up-and-coming medicine, as we may all be familiar with, is the GLP-1 receptor agonists. So those medications are very well received for both diabetes and for weight management, both of which affect fatty liver. And so promoting weight loss, promoting good glucose control really helps the liver release its fat, get rid of it, and that stops inflammation. When you don't have the thing that's hurting the liver anymore, the inflammation can stop and therefore the damage. And once the liver is no longer being damaged or have extra fat in it or being inflamed by anything irritating it, the body has a chance to help fix it a little bit. For some people, they can have the fibrosis reduce by having removed the thing that's injuring the liver. So GLP-1s, we know, are very robust in weight loss and weight management. And so it's been a really big medication in the world currently of fatty liver to try to use concurrently for patients who have both diabetes and fatty liver. You get additive benefit the more of these medications you add. Since they all may help a little bit, the more you have, the greater the additive effect. So GLP-1 look like Metformin with the SGLT2, whatever is indicated for the patient will compound the effect of what they can already do plus the other medication you're putting them on. So how should APPs approach medication selection for type 2 diabetes management in a patient with coexisting MASH, considering both glycemic control and potential liver benefit risks? I think a lot of what I said has answered that. But what I would say more so is it depends, I guess, where the patient is in their type 2 diabetes track. They're newly diagnosed. you might want to start from the beginning. The lifestyle management, exercise, metformin, how high does their sugar go? Where's their A1C? What's their BMI? You have things that you can tweak first and work on and potentially just help the patient get back on track, basically. But if they've been a long time diabetic and perhaps they still aren't under well control, then you may want to go for the big guys. You may want to hit the GLP-1s. You might want to get them on a more robust medication. And that would then help treat both because they are linked. They are both metabolic syndromes. Are there specific diabetes medications that should be used with caution or avoided in patients with advanced MASH or cirrhosis? Yes. We do always have to be careful with people with cirrhosis. We do not want to send them into decompensation. We do not want to give the liver more work to do when it's already teetering on the brink of potentially not totally working anymore. That's how I usually describe it to patients, that you have a big soft liver. Now, if you start to get damage, you get fibrosis running through it like threads. The more and more you get, the more and more they start to link up to each other. Once this fibrosis starts to link and make circles, we get nodules, liver gets bumpy, it gets tougher because there's more and more of this tough tissue accumulating. And that's what cirrhosis is. And in doing that, it is using up areas. Areas are dying off because they're getting hurt and killed. And that's what the fibrosis is being placed where those used to be. So you only get these little areas that are still working, and they have to make up for the rest of the liver. So you don't quite know necessarily if that patient has enough of those small areas that a couple can be taken out and the liver's still functioning fine, or if they are on the brink of decompensation because some of those areas are barely hanging on. So you do have to be careful with patients with cirrhosis and what medications you choose. Now, there is thought that metformin, for instance, could hurt the liver with cirrhosis. We do still have people on it. We do feel some comfort in having patients on it if they are child Q A or B, meaning they have not really had decompensation. Compensated cirrhosis, it's okay to use metformin. Things like pioglitazone, it's generally considered safe in cirrhosis, but if I'm being pretty honest, most of the time we aren't starting patients on pioglitazone because we have better choices. We may want to avoid the sulfonylureas, but I will say that the SGLT2 inhibitors and GLP-1 receptor agonists are safe in liver disease and compensated cirrhosis. Sometimes even in decompensated, you do have to be careful. You have to judge the patient and see what the situation is. Insulin's always safe. So in patients that need a lot of help, they aren't well, we end up with insulin if necessary. And I didn't mention the DPP4 inhibitors, but those are generally safe in liver disease and do have some benefit in the MASH realm of things. There's a lot of categories in diabetes, so I'm sorry that I've missed one, but in general, taking care of diabetes will help fatty liver. In cirrhosis, you have to be careful of the status of the patient, but GLP-1s, SGLT2 inhibitors, DPP4 inhibitors, and insulin are all safe for cirrhosis. Okay, that is the end of my questions. That is the end of what I have for you. Thank you for listening. And if you need any more information, please feel free to reach out to the MASLD MASH Community Network. Thank you.